I would like to invite you into our space together, which tonight will be Brave Space. This is a poem not by me, by Mickey Scott Bay Jones. It's actually a meditation. I'm going to read it. You can close your eyes if you like. You don't have to. Together we will create brave space because there is no such thing as safe space. We exist in the real world. We all carry scars, and we have all caused wounds. In this space, we seek to turn down the volume of the outside world. We amplify voices that fight to be heard elsewhere. We call each other to more truth and love. We have the right to start somewhere and continue to grow. We have the responsibility to examine what we think we know. We will not be perfect. It will not always be what we wish it to be, but it will be our brave space together, and we will work side by side on it. That's a nice way to start. Let's also take a deep breath and think about all those who have died, all those who have suffered because of our cruel and dysfunctional healthcare system. Lift those folks up. Use that energy to be our courage to do this work. I want to share one last thought about the interpretation. Those of us who are speaking, all of us who are speakers, remember to speak slowly enough that there's time for the interpretation to happen. If you get excited, if your tendency to get excited and talk fast, try to consciously slow yourself down, take a breath, slow yourself down. If I see that, I'll do like this so that we can have some good experience for everyone and practice some language justice. So here's who North Carolina Medicare for All Coalition is. We're growing. If you're not a member, go to the website and join. We certainly need your voice, your energy, your enthusiasm.
Hey all, my name is James. As George mentioned, I'll be one of the co-hosts for this evening. Very thrilled to be in this brave space with people from Durham to Raleigh to West Virginia to Los Angeles. Really happy to be in this space with y'all. The first thing that I'm going to cover is who are we as a coalition and what do we believe in? As everyone is, I'm sure, aware, we are living through the intersection of two historical events that are not only happening simultaneously, but which are also having a disproportionate effect on Black lives. On the one hand, our society is currently reckoning with a nationwide uprising against police violence, while at the same time having to deal with the COVID-19 pandemic. The fact that police violence and COVID-19 hit Black communities and other marginalized communities the hardest should come as no coincidence. In fact, it's sort of the opposite of the coincidence. It's determined by the system that we were born into. We live in a country whose very foundation, whose very DNA is constituted by the double helix of white supremacy and capitalism. This is obviously true when it comes to the police, but as our guests for this webinar will describe shortly, this is also true when it comes to our healthcare system. As such, for the sake of Black lives, for the sake of Black health, we as a coalition believe it is a moral necessity to dismantle and transform this system, to instead of perpetuating the status quo that views healthcare as a commodity that only a privileged few can access, we believe that healthcare is a basic human right that should be given to all people. And that it should be something that shouldn't be denied to someone because of their race, their gender, their immigration status, or their inability to pay. We're a coalition that's committed to systemically transforming our conception of how we deliver healthcare away from the current for-profit employment-based healthcare system that excludes, that bankrupts, that kills so many of us, to an improved Medicare for all system that heals, that will save people money, and that includes everyone. So to achieve this reality, our long-term goal is to pass the Medicare for All Act, otherwise known as HR 1384. What is HR 1384? HR 1384 is a bill that would give health coverage to all U.S. residents, regardless of their immigration status. It would eliminate all out-of-pocket costs, so that means no premiums, no copays, no deductibles. It would cover all medically necessary services that many health insurance plans do not cover fully, like dental, vision, mental health care, prescription drugs, and long-term care. And it would ultimately save money in the long term with measures like global budgeting and by allowing the government to negotiate down prices for prescription drugs and medical devices. All of these measures have always been necessary, but they're especially necessary now during a global pandemic. We need Medicare for all now, but we need you to help make Medicare for all a reality. So how can you help? Well, throughout this webinar, between each speaker, we will talk about various action steps that you can take to join and support the North Carolina Medicare for All Coalition. Now, as George just mentioned, we hope that everyone on the Zoom call, everyone watching on Facebook Live, will go to www.ncm4a.com to sign our petition and also to sign up to participate in one of our working groups. We're also on social media. We have a Facebook, a Twitter, an Instagram. We just created a YouTube page, and we'll be using those different platforms to spread the word about future events like this, and also to help inform the public as to why we need Medicare for all right now. So now that we've talked about who we are as a coalition, now that we've touched on how folks can keep in touch with us, let's get into our roundtable by welcoming our first guest. We're absolutely thrilled that he made the time to come speak to us this evening. He is a policy analyst at the North Carolina Justice Center, where he blends research, data visualization, legislative advocacy, and community empowerment to help expand healthcare to all North Carolinians. Please join me in welcoming William Munn.
Good evening, everyone. Give me just a second here. Sweet. All right, can everyone see my screen?
Yeah.
Great, awesome. So I'm going to talk a little bit about how we got here, how the legacy of slavery has impacted present-day health disparities in North Carolina. So one might ask, what is Rutherford B. Hayes' decision to withdraw the remaining federal troops from the South in exchange for being declared president in the contested election of 1876 have to do with present-day health inequities in North Carolina? And I argue more than one might think. The Compromise of 1877 awarded Hayes the presidency, but it also removed federal troops from the South. It killed Reconstruction, ushered in Jim Crow, and structural racism has dominated Southern domestic policy ever since. So I like to couch this by saying that the ideology that allowed that to happen created policy. And that policy has created outcomes that has brought us here to this present moment. Today in 2020, whites are, only 10% of whites are uninsured compared to 12.6% of blacks. 59%, and this was a couple of weeks back, of all COVID-19 deaths are whites, but they make up 70% of the state, while blacks make up 22% of the state, but 33% of all COVID-19 deaths. So that's flipped around. Twice as many African Americans live in poverty. Life expectancy is lower, and median household income is lower. These data points didn't happen by accident. Seeing this, we really have to recognize that any serious consideration for addressing these disparities have to be, and that we have to acknowledge the ever-present and insidious role of white supremacy. The ideology necessary to justify bondage of human beings, the exploitation of their labor, the implementation of Jim Crow, and the present-day denial of the compounded impact these systems have had on every facet of present-day African-American life, including health outcomes. And I'm not just the one saying this. You know, there's a lot of literature that argues this very, very well. And I think the most clearest example of this is Deep Roots by Achara Blackwell and Sen, who explore the relationship between the deeply entrenched and political and racial views of Southern whites and their regions, and this region's slaveholding history. They use examples of current political attitudes of whites in Greenwood, South Carolina, versus those in Asheville, North Carolina, where the enslavement proportion was almost inverse there. In a 2014 article, they argue that after the Civil War, Southern whites living in those areas, traditionally reliant on slave labor, embraced political and economic incentives to reinforce racist norms and institutions to maintain power over the newly freed blacks, power that has been used to deprive them of wealth and health through intentional and deliberate policy up into the present day. So this is a map of the slave population by county in 1860. And my colleague Nicole and I hypothesized that racist ideology and policy took deeper roots in the regions with higher proportions of enslaved people, allowing systems of oppression and isolation to flourish long after emancipation. We explored the relationship between the prevalence of slavery in North Carolina in 1860 and present-day socio-health outcomes. And we expected to see a relationship between the number of enslaved and the various indicators, suggesting that while the formal institution of slavery was dissolved 150 years ago, intentional forms of control have stretched into the 20th century, blunting African-American progress through policy designed to keep them disenfranchised, dependent, and unhealthy. So to test our hypothesis, we gathered slave population data from 86 counties that made up North Carolina in 1860, and we matched them to 23 present-day socio-health outcomes. So we matched the old county slave population to present-day factors. And we expected to find that counties with the largest proportions of enslaved people would be associated with more negative socio-health outcomes in the present day. We chose factors like preventable hospital stays to food insecurities, based on the theoretical assumption that structural racism would impact the variance in these indicators. And of these 23 factors, 16 of them reported statistically significant relationships with the county's slave population, the strongest two being intercorrelation between present-day percent of African Americans and food insecurity. So with the percent of African Americans so strongly correlating with percent of county enslaved, we ran a second model between that variable and the other 22 socio-health indicators. Percent African American per county had the statistically significant relationship with 17 of the other 22 indicators. So once again, we're seeing that there's a strong relationship between percent Black and negative outcomes, and negative present day outcomes. Again, the strongest relationship being food insecurity. So modern policy like Medicaid expansion would deliver benefits to these communities traditionally marginalized. In fact, counties like Martin, Robeson, and Duplin County would see 14%, 11%, and 10% of their county populations respectively gain health insurance within 3 years of expansion. Counties with whose health has been most likely compromised by the weight of historical precedent stand to benefit most from Medicaid expansion. I'm happy to answer any other questions later on. I didn't have as much time as I would like to delve deeper, but I hope this gave us all an overview as to the relationship between slavery, white supremacy, present-day outcomes, and policy that have impacts on African Americans today. Thank you so much.
Thank you, William. We'll now be moving. Yes, we'll now be moving towards an explanation of the Healthcare Emergency Guarantee Act. As William mentioned, by providing that really important historical and scientific context, the health disparities that we're seeing today between Black and white people are sort of our inheritance from a history of slavery, so much so that you can directly correlate the percentage of slaves in certain counties to negative health effects that manifest themselves in Black people living in those counties today. Obviously, as we talked about earlier, this coalition has been fighting for the passage of HR 1386 since before the pandemic. But since the pandemic started, we've seen that the people who are in the most exploitative jobs are the people who are most likely to get this highly, highly contagious virus. And one of the legacies of slavery is, unfortunately, people of color are more likely than their white counterparts to occupy those jobs. So, recognizing that we're in an emergency, we are pushing to pass the Healthcare Emergency Guarantee Act, which will specifically rise to meet the public healthcare needs of people during this pandemic until there is a widely available vaccine by authorizing Medicare to fully cover the costs of all medically necessary healthcare costs for uninsured patients, regardless of their diagnosis, and to fully cover the out-of-pocket healthcare expenses for all people with insurance as well, regardless of their diagnosis. Now, again, we need people power to make this happen, to counteract the forces behind Big Pharma and the health insurance lobby to ensure that public health is finally prioritized over private profit. So one way you can help us achieve this is to go to www.ncm4a.com/campaign. There you'll be able to find a congressional letter that you can sign on to. And we also encourage folks to talk to your friends about this and talk to your friends about the Emergency Healthcare Guarantee Act and why it's so necessary to protect the most marginalized in our society from catching this virus, which unsurprisingly is targeting the most marginalized in our society. So again, check out www.ncm4a.com/campaign, and please sign and share that letter to everyone you know so we can create as much pressure as possible on our elective representatives to deliver us the healthcare system that we deserve during this pandemic. Now we'll be moving forward to our next esteemed speaker. Dr. Susan Rogers is the president-elect of Physicians for a National Health Program. They are volunteer attending hospitalists and internists at the John H. Stroger Jr. Hospital of Cook County, and they are the assistant professor of medicine at Rush University. Please, everyone, join me in welcoming Dr. Susan Rogers.
Okay, here we are. All right. Okay, I'm going to talk about inequities and why we have inequities here in this country. And I think that there's no question that we have them, and we could talk about numbers, but I think that to understand why we have these, we have to look back in a little history. And I appreciate what Will Munn was talking about in North Carolina, because I didn't know much of that. But anyway, let's see here. I want to talk a little bit about some of the federal policies and all that have led to these inequities. Now, just a little bit about my background. I spent most of my medical career caring for minority patients at safety net hospitals and clinics in Chicago. And unfortunately, the economics of healthcare in this country have made poor patients the ones that no one wants to treat. The inequities have been here since slavery, and the policies and legislation that have been adopted in this country have ensured their continuation. I like the term inequities more than I like disparities, because when you talk about disparities, it just means that there's a difference. But inequities imply something that's unfair, something that's unequal. There's an injustice component to that. And I think we have to make sure that we use that term and not just disparities. Now, racially segregated housing was created and racially segregated neighborhoods. That's a key contributor to the inequities that we see today, because it concentrates poverty in these areas and it denies and minimizes the resources that these neighborhoods need to function. And it's not just good health, but it's for all the other things the community needs to thrive, like jobs, transportation, education. A lot of these are missing in Black segregated neighborhoods. So segregation in this country just began, and it was created and reinforced the illusion of white supremacy and Black inferiority, which has been alluded to before. So let's just talk about some of these things that caused it. So let's look at FDR's New Deal, which is often referred to as jump-starting this country after the Great Depression. Now, when he started the Social Security Act, and this gave benefits to people over 65, purposely excluded from this benefit were farmers, who in the South were mostly Black. It also excluded domestics, who were mostly white women. So this—
There were a lot of farmers who were Black in the South.
In the South, there were a lot of, actually right after Reconstruction ended, there were more Black farmers in the South than there were white farmers. But it purposely excluded Blacks from this benefit. And this is something that many people depend on to this day. He also developed a system, ADC, and this was the Aid to Dependent Children and Families. And this was initially just for white women who had had children and needed assistance. And it was only decades later that it expanded to support Black women. And that's when it became known as an entitlement. Before, the white women who received this benefit, they were worthy of it. But now that it spread to Black women, it was considered an entitlement to them. Also, the Farm Security Administration was to help farm owners during a time when prices were high. So what they did was they said that you don't have to farm and we will pay you for not farming. And so what that did is it gave the white farm owners a lot of money, but it gave the Black sharecroppers nothing. And this was made to be like that. And so, you know, Black sharecroppers, just not that they had much to begin with, but they were just totally removed from any benefit there. So let's talk a little bit about what happened with the Federal Housing Association, which established government secured mortgages. Back then, Blacks couldn't get mortgages because of redlining and restrictive covenants. There were predatory contract mortgages, which were more of a renting ownership hybrid, whereas if you missed one payment, you would totally lose anything you had in your home. And this predatory nature of this has continued. And even in the 2000s, we had the subprime mortgages that were predatory. They preyed on minorities who could have been eligible for a regular mortgage, but they were directed by the banks to receive those. And of all the home ownership loans back after when the New Deal started between 1934 and 68, whites received 98% of those mortgages. Now, let's look at the GI Bill. And if you look at the GI Bill, this is a program that was designed so that GI who were coming home, they could go to college, they could get skill training so that they could get into another career, they could get home loans. But Black GIs were hardly eligible to any of these benefits, all right? Less than 100 out of 67,000 home loans went to Black GIs. Only 2 out of the VA home loans went to Black GIs. The training facilities were segregated, so Blacks couldn't go there. The GI Bill for tuition, the colleges in the South would not admit these Blacks. And the Tuskegee Airmen, they weren't allowed to become involved in what was then a growing commercial airline industry. So all of these programs that people tout, this is never told when you learn history, all of this disenfranchisement of Blacks. And this is just a chart. This is a little bit dated, but there is now newer data. But this refers to what we call concentrated poverty. And concentrated poverty is where at least 30% of the population lives below the federal poverty line. And what this shows, this purple line are Blacks living in concentrated poverty. Whites are in the green line. And what it shows is that 35% of in Chicago, of poor Black people live in areas of concentrated poverty. Now, those neighborhoods have very little. They don't have good functioning schools. They don't have access to transportation. They don't have healthcare facilities. They don't have jobs. It's just devastating. And the people living there, because they're so poor and everybody around them is also poor, it's just living for survival. And so it's difficult to plan ahead if you're worried about what you're going to have for dinner tonight. Whereas the whites in Chicago, less than 5% of the poor whites in Chicago live in concentrated poverty. So those whites still can live in a community that has good schools, that has grocery stores, that has parks where they can walk down the street without fear of violence. So white poverty is not the same as Black poverty. So then white people say, well, I worked hard, I got myself out. It is not the same. Believe me, Black people have worked hard all along. And so what has happened is that health access has evolved around the same dividing lines that have been created by these policies, you know, between whites and Blacks. And the private-based healthcare system we have now, it exists partially to maintain these hierarchies. We have employment linked to healthcare, and knowing that Blacks are disproportionately unemployed, it's a direct mechanism to keep Blacks from receiving healthcare that's needed. And so it's no surprise that the benefits that this results in the inequities that we see. And I think we have to remember this, is that there can't be a group that is disadvantaged without there being a group that is advantaged. And if you look at what the New Deal and what the GI Bill did, that was the base for building the white middle class. They benefited from all that, and that is why there was this white middle class now, and it explains why there is such a wealth gap. So that I think we have to be clear that is where this whole sense of entitlement comes from. And no one can be entitled unless someone else has that entitlement taken from them. So I know I'm over my time. I'm sorry.
No apologies needed. Thank you so much for sharing that and adding even more essential historical context to our work here. As you mentioned, the past is not past. We're still living in it, and a lot of those racial inequities we're still dealing with today. So we're now going to be moving to another action step before we get to our next speaker. This action step involves engaging with our congressional representatives and candidates. As you can see on the slide, we have a link that includes a bunch of information that we hope will empower folks to engage with congressional representatives and candidates. Obviously, lobbying isn't everyone's cup of tea. Obviously, we need to do much more than that. But for people who have the time and capacity to do so, they can use this informational toolkit that includes things like how to contact your representative, recommended questions and framings on how to best persuade your rep on the question of Medicare for all. But more than just conversational tips, this coalition and this information packet gives people a portal into a network of Medicare for all advocates all across North Carolina who can not only give advice, but can also, in certain circumstances, literally attend the meeting with you, or the Zoom call, I guess, during this pandemic, and give you the support to help you go into that meeting feeling confident, but also feeling like you're not alone and knowing that you have an entire coalition behind you who is supporting you. So with that said, we will now be moving on to our next speaker. She is the executive director of the Zeal of Xander. Everyone, help me welcome to the webinar, Zay.
Thank you all so much for the opportunity to speak. I do not have a slideshow to show you, but what I do want is to just give you a realistic view of what can happen. In 2018, April the 24th, 2018, I went to the hospital for or a doctor's appointment just for a anatomy scan. I was 22 weeks pregnant. And when I went to the hospital for an anatomy scan, they could not find my cervix. So the news that they gave me was, today, what we're going to do is we're going to send you to UNC, and then you're going to get a cerclage. Going to go in, gonna stitch up your cervix, and then we'll keep you overnight, and then we'll send you home tomorrow. Well, that was not how my journey ended. I went to UNC, and the news that I was delivered was that you are too far along, you're 2 centimeters, and we cannot do the cerclage. Today, you're gonna have to have your son, and he will not survive. So I'm looking around at the situation, and I'm thinking, wow, I planned a baby shower, not a funeral. How am I going to be able to get through this? So I called, like any child would, even if the child is nearly 40 years old, I called my mother. And my mom had experienced 5 child losses before she had me in the early 80s. And she and my dad and my best friend hopped in a vehicle and drove 11 hours. And they made it to North Carolina, April the 25th at about 9 o'clock, just before Xander was born. Xander was born at 15 ounces and 11 inches long. And so my task on that day was to say hello and goodbye at the same time. And when a lot of people ask me, what was it like doing that? The only thing that I could say is that it's like when light and darkness meet in the same spot, right? Because he was definitely the light of my life. but it was also a very dark time. In 2018, North Carolina had 806 infant deaths, infant losses. 350 of those were Black. In 2018, Pitt County, North Carolina had 11 infant deaths. Every one of them were Black. Every single one. So we have an issue. We have a problem. The problem is that a white woman with a GED has a better birth outcome than a Black woman like myself that makes nearly 6 figures and has a master's degree. When they told me that they were not going to be able to save Xander, my immediate question was why? And they said, well, he is only 21 weeks, 6 days, technically 22 weeks. If he had been 23 weeks, we would be able to save his life, or we would be able to intervene. What they did not take into consideration is that just the week before, they changed my due date by 10 days. So if they had allowed my due date to stay the same, they would have at least been able to intervene and try to assist to save his life. But because they did that, it was not possible. So statistics show that 1 in 4 women will lose a baby, right? Those are facts. 1 in 4 women, whether or not you're Black, whether or not you're white, whether or not you're Hispanic, Asian, Native, 1 in 4 women will lose babies. However, Black women are 2.5 times more likely to lose babies and 4 times more likely to lose their lives. There is a problem that's going on in our healthcare system. And our healthcare system was not designed to assist Black people, right? So we can be honest and say that. The tough situation, the tough conversations that we're having is in this space. And in this space, we are all brave enough to say that the Constitution, that the policies and procedures that were implemented and that were structured for the United States were not meant for Black people, because Black people were not people, we were property. And so we have to make some changes that will take us from property to people, and we all have to be responsible for that. And so what I'm tasking everybody is that the Black community needs to learn that we are deserving of resources and coverage. Absolutely deserving of it. We shouldn't have to beg for it. We should not have to rally for it. We should not have to cry for it. We should be able to have equal and humane services. When I contacted my doctor and I told them I'm experiencing some cramping, I'm experiencing some spotting, it's some things that's going on, I think I feel my son in my cervix, they said, he's too young for that. You're probably just constipated, right? That was my diagnosis. You are probably just constipated. If they had done a vaginal ultrasound, the Tuesday that I went in before my son was born, they would have noticed that my cervix was funneling. But to them, my complaint was not valid, right? So we need in the Black community what we have established here on this screen. We need educators and we need advocates. And all of us have to be responsible for that. It is important for each of us to ensure that we are putting individuals that are change agents in office, not just going into a voter's booth and choosing who we've seen most on a sign or who we've seen most on a television screen. We have to be responsible for choosing the accurate people to put in office so that everyone will have access to care. There should never be a time where we live in the most developed country in the world and we have the worst birth outcomes than a third world country. There should never be. If we are in a situation and a space that we can take a heart from one person and put it in another person and it works, but we cannot prevent Black women from dying from birth complications, and we cannot prevent Black children from dying because they have been sentenced because they're Black. We have to be strong and right and not strong and wrong. right? So I'm tasking everybody on this webinar, on this cast, to stand firm in your belief. And the belief that we should all have is that everybody deserves to have access to care. Everybody deserves to be healthy. Everybody deserves to live a good and functional life. And we have to be vocal about that.
Amen. Amen. As so many people in the chat have already said, on behalf of the coalition, you know, we're so sorry for your loss and that you had to go through that. But this stuff is personal. It's not just about data. It's not just about, you know, historical analyses. It's the fact that we have to live with these things every single day. And you're right, we need to shift away from viewing us Black people as property and as humans. This isn't just about healthcare. It's about realizing and affirming each other's humanity and actually treating each other as human beings as opposed to points of profit. Thank you again so much for sharing that story. And there's so many stories that need to be told, like that one. There's so many stories of people who have lost loved ones and are dealing and drowning in debt, not because of anything they did wrong, but because of the color of their skin, because they didn't have enough money, because they lost their job because of a pandemic, or they got infected on the job during this pandemic. So we want to lift up everyone's stories and the stories that you'll hear tonight by sharing this webcast on any social media platform that you use, using the hashtag Black Health Matters and the hashtag NCM4A. Very important that you use those hashtags so the coalition can find what you have to share and help boost, retweet, and amplify your voice to the wider world, because these voices like Zay's, voices like everyone who's going to be speaking on this call need to be lifted and need to be amplified for us to realize Medicare for all and to realize each other's humanity. With that being said, I'm going to pass it to my co-host, George, who will be introducing our next guest.
Indeed. And thanks for sharing that story. I'm so sad that happened to you. I'm a way, not super old, but a way old lady. And my mom, who was pregnant 13 times in 15 years in Lincoln County, North Carolina, used to tell stories about, of the 7 live births she had, but the 6 that weren't, her hearing folks say, oh, well, you can just let that die because, you know, they're, you know. And I never imagined that made it into the 21st freaking century. I'm really using restraint, y'all, not to cuss, because, you know, I'm a grown woman. So Dr. Elaine Green. Dr. Elaine Green is a practicing obstetrician and gynecologist. She is part of and in a lead role with Healthcare for All NC, thank you, Dr. Green, the North Carolina Medical Society, Old North State Medical Society, and the North Carolina Medical Board. Dr. Green.
Thank you. And thank you, Zay, for that powerful, powerful presentation. And I, too, am sorry for your loss. Thank you for inviting me to participate in this very important discussion on Black health and racial justice. On March 26, 1966, at a press conference in Chicago before the annual meeting of the Medical Committee for Human Rights, Dr. Martin Luther King is attributed to stating, of all the forms of inequality, injustice in health is the most shocking and inhuman. This statement was profound then, and it still holds true today. You all know the statistics. Health disparities are pervasive in the United States. For almost every health status indicator measured, comparing health and health outcomes of Blacks and other minorities to whites in America, disparities exist. Blacks experience much more and higher rates of chronic illnesses such as diabetes, hypertension, and cancer, and they experience poor health and poor outcomes than white Americans do. Black children have a 500% higher rate of deaths due to asthma. I said 500% higher rate of deaths due to asthma than white children. Maternal and infant mortality rates are much higher for Black women. And we know that 50% of maternal deaths in the United States are preventable. Yet maternal deaths in the United States are not decreasing as they are in other countries. They are increasing. Why is this? Why do we see all of these inequities in health among Americans? I believe that disparities exist because of structural, implicit, and explicit racism that has existed in this country from the foundations of slavery. These factors are unseen or denied by many and are bold and in your face to most Black people. And I believe that these structural and explicit forms of racism exist to prevent Blacks from obtaining and enjoying the same economic benefits as white citizens do. Regardless as to where one starts assessing disparities and their effects on Blacks, it always ends with the fact that the ability of Blacks to make money for our families and hand it down through the generations has been stolen from us, starting from slavery, and it continues today. It always boils down to the money. Our ancestors all had jobs during slavery, but they did not get paid. And when government-sponsored slavery was discontinued, the structural racism and racial hatred was not discontinued. The implicit bias was not discontinued. These facts ensured and solidified severe limitations on the financial success of Blacks. Let's consider the most common reasons for healthcare disparities in the United States. Social determinants of health and lack of health insurance. Social determinants of health are conditions in which people are born, they grow, they live, and they work, and they affect health status. Examples are poverty, lack of education, unemployment, housing, where you live, environmental factors, and food insecurity. All of these are also factors of income. These negative indicators or determinants are more prevalent in Black communities because they lack the income that would help them to alleviate them. These determinants reinforce and institutionalize inequality and unequal care, and they can result in structural racism and can block equal access to health care. Black Americans' household income was 58% of whites in 2011, according to the census, and the median net household income was $6,313 compared to $110,000 for non-Hispanic whites. This was a 15-fold difference. If this economic inequality was reversed, negative social determinants of health could be removed. There would be less poverty, less unemployment among Blacks. Blacks could live in healthy communities, obtain higher education, and so on. Income inequality contributes to health disparities. However, the evidence shows that even when instances where income is not a factor, racism still is. And when Blacks try to improve their housing situation, racism is a roadblock when they can't get certain bank loans, the redlining that Dr. Rogers discussed. And also there are situations where when sellers found out the race of a buyer, then the property was no longer available. The other major factor which can have a profound effect on disparities are the high numbers of uninsured in the United States compared to other industrialized nations. Most Americans erroneously believe that those without health insurance do have access to health care when they need it, but studies show otherwise. When the uninsured are asked why they don't have insurance or a regular source of health care, most often cost is the reason. And a high proportion of the uninsured are Black and are unable to afford quality, cost-effective health care in the United States. And this causes many Blacks to suffer from high rates of preventable illness and death. Again, this comes right back to the root cause of disparity, money and racism. There's compelling evidence compiled by multiple sources, including the Institute of Medicine, the Henry Kaiser Foundation, and others, that a lack of health insurance in the United States can cause poor and unequal health. It's believed that about 1/3 of the health disparities that we see here in the United States could be improved if health coverage was universal. And of course, Black and minority populations account for the higher percentage of the uninsured. In the Institute of Medicine study, they showed that when people were compared that had insurance versus those who did not, that being uninsured was a hazard to one's health. The uninsured received less preventive health screens, they got less cancer care, and had poor cancer outcomes. If they had chronic diseases, they were less likely to receive appropriate care to manage their health conditions. If they had cardiovascular disease, they were less likely to get testing such as angioplasties, and this all resulted in increased mortality. And then in 2009, the Institute of Medicine did another follow-up study, and they found the same things, that if you were not insured, you could not get health care in the United States. But unfortunately, by then, the recession had hit, and even more people were uninsured. This led to a recommendation from Congress that we needed to move toward universal health coverage, and it needed to happen now. Of course, that didn't happen. The Affordable Care Act was passed, which was helpful. It got about 20 million more people insured that were not, but there were a lot of people who could not afford to enter the healthcare exchange, so gaps still existed. And then Republicans in Congress took every opportunity to dismantle the ACA, and now there are even large gaps in coverage. So to get more people insured, the ACA did not go as far as we would have liked, and still about 30 million Americans are uninsured. Medicare for All is the only true single-payer universal healthcare system that enables everyone to access healthcare that they need, and if enacted, could have a profound effect on reducing healthcare disparities. It's estimated that over 1/3 of the disparities would be eliminated if Medicare for All was enacted. Our current corporate profit-driven system with public safety nets for the poor is broken and in dire need of sweeping reform. And we see that even more clearly now that we're in the midst of the corona pandemic. Again, we see disparities in access to healthcare and disparities in healthcare outcomes, with minorities, African Americans experiencing disproportionate rates of infection and death. And until we enact universal health care for all, we're going to continue to see these disparities. Our profit-driven system is expensive and denies basic rights to care. As our nation's largest purchaser and regulator of healthcare, Medicare could be a leader in reducing healthcare disparities. Every American would have access to healthcare, and Medicare could shape policy to even further reduce disparities. When President Lyndon Johnson said in 1965, at the signing of the law that created Medicare and Medicaid, no longer will older Americans be denied the healing miracle of modern medicine. No longer will illness crush and destroy the savings that they have carefully put away over their lifetimes so that they may enjoy dignity in their later years. We must now say, no longer will any American regardless of their race or economic status, be denied the healing miracle of modern medicine, and no longer will illness crush and destroy the savings that hardworking Americans have carefully put away over their lifetimes so that they may enjoy dignity in their later years. It is time to close the gap in healthcare coverage and develop a more just healthcare system for all. And we can do that with Medicare for all. Thank you.
Thank you so much, Dr. Green. We absolutely can do that with Medicare for all. So we have an action step for you. You can hear Nichelle's story before we talk about that action step.
But according to what I bring home, a $10,000 deductible is not feasible for my household. Then the place we reside in here recently has created the perfect conditions for this virus to wreak mass havoc, which there is no cure for. And it is killing us at a rate that none of us have ever seen in our lifetimes. What about that irony? There is no room to get sick, but now we must literally walk around on eggshells in an invisible bubble to protect our immune systems and continue to pay these outrageous premiums, now more so than ever before. If you have an underlying condition, you must stay inside. And making certain that you have healthcare coverage is an essential to your existence, as essential to your existence as having water for your body's hydration purposes. This is non-negotiable for us. Yet, there are so many of us that do not have coverage of any kind. Unfortunately, in this world, some of our elders are choosing right now between purchasing groceries or purchasing their monthly meds. I have a family member who has gone on to be with their creator because they stopped taking their blood pressure medicine. I don't know exactly why, but I am pretty sure that money played a part in that decision. There were 3 small children in the household, so I know that that laid on her heavily as well, having to choose to provide for her family or having to buy prescriptions that were a necessity to her life. I may be wrong, but I know that this is a storyline that fits so many of Americans across the nation. Going without medicines that are essential to your life sustainability or providing hopefully for your family is a decision that no one should be forced to make, but we are, lots of us across this nation. As a mother of a teen.
So now I get to introduce, I believe, I've got to make sure I've got the right slide. So I'm not going to say anything till I know. Which is your cue, Sister Rebecca, to go to the next slide. Because I trust everyone's read this and it's awesome. Great inspiration. But yes, our next Take Action opportunity. July 20th, the strike for Black Lives. Participate if you can. Share the information with everyone that you're able to share it with. And go to the website, j20strikeforblacklives.org. So now it is my deep honor to introduce Darian Smith. Darian is the VP of the Eastern Region of UE Local 150, North Carolina UE Eastern Region VP. He is a member of UE Local 150, and of course, as a member, fights vigorously for workers' rights and collective bargaining, the Workers' Bill of Rights, which includes expanding Medicaid, working for Medicare for all, increasing wages, creating better standards for work and safety, and part of the UE Local 150 Safe Jobs, Save Lives campaign, which has been really active since COVID-19. Darian. I know you're here, Darian. We saw you earlier.
Can you hear me?
Yes, sir.
All right, great, great. First of all, I would like to thank NC Medicare for All for inviting me. Brother Dominique Harris, who is the Charlotte chapter UE 150 president. He invited me to be on this call, and I definitely appreciate you all allowing me to share a few words with you. Also, I am a member of the historical organization, Black Workers for Justice. We have been doing a lot of this work since forever. Our organization is 36 years strong. We have a member on here, Ms. Naima Muhammad, who is an original member and who helped start this crusade for our Black communities. So I do appreciate everyone allowing me to speak. The solution workers need are straightforward. Nurses, healthcare workers, transit workers, food service workers, domestic workers, and other essential workers need personal protective equipment. Frontline workers need hazard pay and paid medical leave. At the same time, there are still millions of people out of work and struggling to make ends meet. They need assistance like unemployment, SNAP, rental assistance, and more. Additionally, schools need funding to keep their staff and students healthy while they try to safely return during a pandemic. And all Americans should have access to COVID-19 testing in their local communities. What's more, Black and brown people have been disproportionately impacted by the virus and routinely face racism when seeking medical care. Why are Black people sicker, and why do we die earlier than other racial groups? Many factors likely contribute to the increased morbidity and mortality among Black people. It is undeniable, though, that one of those factors is that care that we receive from our providers. Black people simply are not receiving the same quality of health care their white counterparts receive. And this second-rate health care is shortening our lives. For example, one study of 400 hospitals in the United States showed that Black patients with heart disease receive older, cheaper, and more conservative treatments than their white counterparts. Black patients were less likely to receive coronary bypass operations and angiographies. After surgery, we are discharged earlier from the hospital than white patients are, at a stage when discharge is very inappropriate. The same goes for other illnesses. Black women are less likely than white women to receive radiation therapy in conjunction with a mastectomy. In fact, they are less likely to receive mastectomies. Perhaps more disturbing is that Black patients are more likely to receive less desirable treatments. The rates at which Black patients have their limbs amputated is higher than those for white patients. Additionally, Black patients suffering from bipolar disorder are more likely to be treated with antipsychotics, despite evidence that these medications have long-term negative effects and are not effective at all. In light of these studies, some scholars have concluded that racial disparities in health can be explained by looking to the individuals who are choosing not to prescribe the most effective health and life-conserving treatments to racial minorities. The argument is that if Black people are sicker and are dying at a younger ages than white people, this may be because physicians have racial biases themselves. Their biases cause them to give their patients of color inferior health care, and in so doing, contribute to high rates of morbidity and mortality. But there is also one huge problem that contributes to this negative outlook for African Americans: lack of insurance. And nowadays, most private insurance plans include such high out-of-pocket expenses that it can be too costly to see a doctor, even if you have insurance. This is known as underinsurance, and it is becoming as much of a problem as having no insurance at all. How did we end up with so many people, and especially African Americans, struggling to get the health care they need? The answer is complicated, but the basic problem is that we have a very fragmented healthcare system that consists of a lot of different entities that are looking for ways to maximize their profits. Insurance companies deny coverage to anyone they think might cost them money. I'm gonna read that again. Insurance companies deny coverage to anyone they think might cost them money, and keep huge amounts of money that should be used to care for patients. Drug companies have seen to it that our government cannot bargain over drug prices. As taxpayers, we have to pay whatever price they want. Hospitals are built where the most profitable patients are, often leaving poor areas with little coverage. I want to read that one more time to you. Hospitals are built where the most profitable patients are, often leaving poor areas with little coverage. Doctors may refuse to see patients who don't have enough money. The bottom line is that if there are people who aren't profitable, those people are left out. It would be great if we could point to one thing to fix, but there isn't one thing. The whole system is broken. And it is even more complicated because everyone in the system feels like they are doing the right thing. They feel they are helping people and want to get their fair share. And it's really hard to convince someone that they might be part of the problem if they believe in what they are doing. The only way people really learn about how cruel our system really can be if they happen to get sick themselves. Then they can experience firsthand what it is like to have to worry about going broke or bankrupt to stay alive. But most people don't get sick, so they think everything is okay. And they keep the broken system we have because they are afraid to change, especially if their income depends on keeping the system the way it is. America is the only country in the developed world that is like this. Every other developed country has realized that it's better to make sure that everyone gets the treatment they require. And that's something to think very hard about. No one in those countries has to worry about whether they can pay the bill for themselves or someone they love. They just get the care they need. One of the biggest misconceptions about Medicare for All is that there's just one proposal on the table. In fact, there are a number of different proposals out there. Most people tend to think of the Medicare for All proposals, which are outlined in bills sponsored by Senator Bernie Sanders and Representative Pramila Jayapal. But there are a number of proposals out there that would expand the role of public programs in healthcare. Sanders and Jayapal's bills, which is S1129 and HR 1384 respectively, share many similarities, such as they both have comprehensive benefits, they both will be financed by our taxes, it will be a replacement for all private health insurance as well as the current Medicare program. It will have a lifetime enrollment, there will be no premiums, and all state licensed certified providers who meet eligible standards can apply. A comprehensive single-payer universal healthcare system would significantly reduce anxiety and debt, increase health and happiness, and help the lower and middle classes the most. So if we want a society that's better equipped to handle a pandemic while also being able to provide healthcare for people during normal conditions, we make Medicare for All a reality. Thank you very much for your time.
Thanks so much. We really needed to hear that. Great to get fired up. Thank you so much, Darian Smith. So your opportunity to take action here. Using our toolkit, there's a link here, probably also in the chat. I'm not looking at the chat, but I trust that it is, which gives you the opportunity to have resources to help take action within your organization or within a group you're part of, your church, your singing group, your, folks you get together with Zoom on. There are different opportunities coming up and some of the organizations that are leading that. Black Workers for Justice, as Darian mentioned here. North Carolina Artist Liberation Project. Durham Beyond Policing, fantastic work. Raise Up and Fight for 15 Durham, awesome. There's their Twitter handle, I guess, best way to get in touch with them. Emancipate NC, which is a statewide organization, fantastic statewide organization. Check them out. Check out all of these organizations, and also remember the Black Health Toolkit that you have access to here. Fantastic. Now, I'm really excited to introduce our last speaker, not because I'm excited to make my dinner, but because I am so enamored of and in high regard of Naima Muhammad. Brilliant, wonderful organizer, long-term veteran, champion, warrior when it comes to fighting for justice in all of North Carolina, but absolutely Eastern North Carolina. She is the co-director of organizing at the North Carolina Environmental Justice Network. I'm going to say that again because it was fast and I know we have people doing interpretation. The North Carolina Environmental Justice Network. She serves also on the North Carolina Department of Environmental Quality as the secretary of EJ and the Equity Advisory Board. So when we have a climate where we can all take deep breaths, Naima Muhammad and her work will be part of that we have to thank for that. Naima?
Okay, thank you, George, for that introduction. And I would like to thank Dominique for inviting me to be a part of this event. And it has been very, very worthwhile being here with you all. And Xavier, I just want to grab you and give you a big old hug. Thank you for your story and your courage being able to tell it. I think I would have been boo-hooing too bad. But anyway, stay strong, sister. Okay, and so as Darian mentioned, I am a part of the North Carolina Environmental Justice Network. I'm the organizing director. But Darian Smith also informs y'all that I'm a founding member of the Black Workers for Justice. Which when I first moved back to North Carolina, started out working around issues on workers' rights and workers' right to be organized and union members if they wanted to be. Anyway, but that's not what I'm here to talk about. So I'm talking about environmental justice or environmental injustice. Environmental justice is what we're working to achieve. But a couple of things I want to say real quick before I start talking about my work is I was glad to hear that this is a brave space tonight, because on yesterday I was looking at some videos that were sent to me, and one of the things I heard a pastor say in one part of North Carolina was that he didn't want to be in safe space, he wanted to be in brave space, because brave space meant that he was at a willingness to stay and listen in order to be able to sympathize with you. So the brave space, gives us that ear we need to sympathize with people and to hear their stories, such as we're doing here tonight. And the last thing he said, he quoted this author Shane Claiborne, who said, "To be rooted in grace is to be driven by justice." And I think that as we've all heard the stories tonight, that we are all rooted in grace because we're driven by justice. And so that just really made my day yesterday to hear those two things. And then the last thing I would like to say to all of us, I don't know if anybody been follow the news on Good Morning America the way I do, but this morning as I was looking at it, I'm just gonna say this and be done. This crazy president that we have, who I truly believe is mentally ill, is now going out trying to force local governments to open their schools whether they feel ready or not to open the schools. And the problem that I had in hearing that was, how are you going to tell people to send their children back to school, and you saying on the other hand, all we hearing is how this COVID is on the rise. And so what guarantee do we have that sending our children back to school is going to be safe for them? And I think that we as parents, grandparents, and whatever we are, aunts, uncles, that we need to be making a call to the parents you know, if you don't think it's safe, do not send your children back to school. Opt out for the online. That'll show Trump that he can't control every single detail. He's talking about defunding the schools, the state governments, if they don't reopen their schools. But he don't want you to defund the police for killing people. And then the other thing that he did this morning was talking about pulling out of the pulling the U.S. out of the World Health Organization. And he's solely doing it because the World Health Organization is not saying what he wants them to say. And so anytime somebody disagrees with him, his thing is to get as far away from it as he can, no matter what is good for. And then I listened to a speaker from the CDC talk this morning, and you could tell that he was scared to own up to the truth that the CDC know about this COVID and what it's going to take to make people safe to reopen schools. And as I listened to him, I was like, you know what? You just scared that if you don't say what you want, what Trump wants you to say, that he's going to pull funding from the CDC, like you see him messing with the WHO, the World Health Organization. And so it's really sad to see all these people with this knowledge and understanding and know that they have the evidence to back up what they're saying, so afraid to tell the truth. And it's doing it at the risk of all of us on this webinar and everybody we know in this world that's living, walking, and breathing. We're all in danger when these people don't stand up to the truth that they know about what's going on in this country. And, and then we're now talking about, we need healthcare for all, leave it up to this government we have currently. We're going to all be dead. We won't have to worry about healthcare. We won't be here if we don't do something to make a change in this country. And now that I've gotten all that off my chest, I will briefly tell you the Northland Environmental Justice Network. We are a statewide organization that work with communities that's living with or trying to prevent hazardous toxic waste sites from being planted in their communities. And our biggest fight over the period of our existence has been against the pork industry in North Carolina because of all the concentrated animal operations in the state. In North Carolina, we have 10 million pigs, and out of the 10, and let me say 10 million hogs, because most of them are adult animals. So we have 10 million hogs in North Carolina. But now, and we have 9 million people, so we have more pigs than people in North Carolina. And we also, the pigs are not spread out like the people are. The pigs are concentrated in eastern North Carolina. And Duplin County, which is down in the Warsaw, Wallace, going towards Wilmington area, it has been deemed the hog capital of the world, having 2.2 million pigs in Duplin County, equating to 45 pigs per person. And their next door neighbor, Sampson County, which is like Faison and Clinton and Turkey, when you hear those little towns, they have 2 million pigs in Sampson County, equating to about 32 pigs per person. And Eastern North Carolina Eastern North Carolina has the top 10 hog producing counties in the country. Is in Eastern North Carolina. Even though North Carolina is number 2 in hog production, they're number 2 to second to ours, but they're number 1 in the density of animals. And the land mass is not as spread out as it is in our these animals. They're more concentrated, and they're sitting in predominantly African American, Native American, and Latinx communities. And thus we call this environmental racism. And we say that because we don't believe that this was an accident, that these animals wound up in Eastern North Carolina. When you look at North Carolina as a whole, Eastern North Carolina is like the stepchild of North Carolina. So we have like the highest percent of poverty, and is in Eastern North Carolina. The highest percent of communities of color is in Eastern North Carolina. And so we call it environmental racism. We believe the companies targeted these communities because they perceive these communities to have the least amount of economic and political power to fight them off. And the poor
Naima,
yeah.
Forgive me for interrupting you, but we want to be able to get to some folks' questions. So
Okay.
take maybe, a minute and a half or 2 minutes and tell us the things we absolutely need to hear, and then we're going to at least try to get some questions. Thanks.
Okay. So, well, then quickly, I will tell you that if you follow the slave route in North Carolina, if you follow the route of slavery in North Carolina, you will follow the route of industrial agriculture. Again, lending the definition of environmental racism to why we look like this in Eastern North Carolina. And over the years that we've been doing this work, which has been nearly 3 decades, that we've been fighting this industry to change the conditions that people have to live with, because animals, they're right up on people's backyards and stuff, and they have a waste management system where they use a lagoon and sprinkler system. And lagoon that's filled up with nothing but fecal matter and urine from the animals that's kept in those that's kept in the confined houses that they keep them in. And then they spray the waste out. They use an irrigation system, an industrial irrigation system, to spray the waste out of those open air lagoons. They spray it out into the air and spray it around on crops in the community as fertilizer. It gets on the people's homes and their cars, their clothes, and your body if you're out there. And so it has caused huge health problems for people, a lot of upper respiratory problems, high rates of asthma for children, a lot of high elevated blood pressure, immune problems, and stress and anger for people that they have to live like this. And it has taken away people's basic human right for clean air and clean water, because most of these communities are on well water. So now with all the waste being sprayed out, so you have groundwater contamination. And so people are
Well, Naima, that is our opportunity to shift and try to get to our questions and answers. I'm sorry it's such an abrupt halt, but technology may be taking a part in that. You're frozen, but you're going to get right. But we also are going to move on at this point. Rebecca, I don't know what our next slide is, or if it's just the Q&A slide.
Just the
There should
Q&A,
be an action.
George. It's just
Okay,
the
then.
Q&A, so I'm not going to go up. I'm not going to share the screen again. We could just do Q&A.
All right. So it would be really good to go back to some of the beginning questions. I'm trying to look for one. Does someone besides me have seen a question and know someone they want to pose it to?
I've got some questions queued up, George, that
Very good. Thank you.
Our chat moderators have been sending me privately. The first question we have is for Dr. Susan Rogers, if she's still on the call. One of your slides talked about the creation of entirely separate public health and medical systems. Can you explain more about how this is connected with racism?
Sure. When we talk about a public health system, well, there's public health, which is, like addressing COVID, but a public health system like where I worked, Cook County Hospital, is funded by Cook County. It's a government-funded institution. We see anyone there regardless of their ability to pay. And it's public in the sense that it is not there to make money. It is there to provide a service, whereas all your other hospitals are there to make money, whether they're for-profit or non-for-profit, they are still there to make money, and you have to be able to show that you have insurance for them to see you. Now, by law, anybody can go to any emergency room that they want, but if you need to be admitted for care, unless it's an emergency, you need to show that you can pay for it. So that public system is totally separate in the sense that it's funded by government, and a lot of teaching hospitals are also in that thing we call public or safety net hospitals. And they provide care like trauma units, burn units, neonatal intensive care. So they provide services that a lot of other places won't, and you still don't have to pay. You still will get that care regardless of your ability to pay. But that's the difference. So you've got a for-profit system that is there to make money, that attracts people who can afford to pay. And then you have another system that, you know, historically has not been for that group of patients. And so you end up with kind of a two-tiered system. Medicaid and Medicare, which does not cover the cost of providing that care, often is, you know, it's the places where people go for that care can be a little bit different sometimes. Not always, but it's the funding, yeah. Does that answer the question?
Yes, it does. And we have another question for you that's somewhat related. The questioner asked, some say that Medicare for all wouldn't end racial bias. Can you explain why it's still important to take this step, and why you and your organization are directing your energies towards this work to get Medicare for all passed?
I mean, you're correct. There's not one thing we can address that will eliminate racism. Racism is systemic. It is part of the infrastructure here. But I still think that we are still entitled to be healthy. I still believe that healthcare is a right. And as long as our system, which is a for-profit driven system, puts up financial barriers before you can access care, we need to break down that barrier so at least people can be healthy. And so even though, yes, it will not eliminate racism, it's still a right. It's just like water. It's like, you know, even though water isn't a right because you have to pay for it, but I'm just saying that, you know, we still need to provide that health care to everyone. It's, to me, it's no different than if you go out to a restaurant, you want the person who's cooking your food to be healthy. You want the person who's standing behind you in line in the grocery store to be healthy. You want the teacher who's teaching your children to be healthy. And so it's to our benefit that everyone is healthy. It's not, it's, you know, sometimes I look at, when you walk to a store and the doors automatically open, you know, the automatic, why is that there? It was because of the American Disabilities Act. So that was done there to help people who are disabled, but we all benefit. We all benefit from those doors. If you have a baby stroller, you benefit from the ramps and the sidewalk that allow you to cross the street that were put there because of the American Disabilities Act. So this taking care of everybody is to everyone's benefit.
Yeah. Yes. Thank you so much for explaining beautifully the human interconnectedness that is always present, but I think is especially present now in the midst of this pandemic that's so contagious. So do we have time for more questions?
Well, we've actually pressed people for this extra 9 minutes, but if you take one question, and if you don't catch the one that I saw in chat, I'll do that last one, and we should have y'all off of here in another 8 to 11 minutes. Go ahead, James.
Okay, great. So this question was directed towards Will and or Dr. Green, whoever wants to answer this question. Y'all talked about the history behind how these racial and health inequities are so entrenched. in our culture, in our society.
Inequidades en salud y por qué son tan
With that in
arraigados.
mind, what can we do to start dismantling these systems and eliminating them, with them being so entrenched? I think Will has left the call, so Dr. Green, do you have any thoughts on this?
Well, we know that the more people that can have access to healthcare will reduce the disparities in health. We know that we have to tackle racism in America. I think we saw this plainly with the most recent death up in of George Floyd, you know, and we just have to have the conversations. We have to do it, and there are ways to do it. People aren't born racist; it's taught, so it can be unlearned, and we can do better. And I believe that we will do better. I don't know how much time it's going to take, but I am encouraged by the things that I have seen. You know, after George Floyd's death, when so many people came together, regardless of their race, and spoke out. We hadn't seen it on that level before, to my knowledge. So we just have to, I think it would help if we have our institutions to take part in organizing and educating. And so I think we just have to make a conscious effort to do better. And I think we can do it. We can do it.
Agreed. I think we can do it too.
Okay.
George, do you want to cover the last question?
Well, yes. Oh, it went away. I'm going to find it now. Yes, here it is. Stop. Go away. I'm going to read the question, and I'd like to ask the folks who haven't spoken yet to respond. Maybe each of them give a brief response. I know Ms. Bell, I think I've got the right name, the right last name. I know I'm not going to get the first name right. So Ms. Bell hasn't spoken. If Darian is still on the call, I'm pretty sure we lost Naima, but those two folks, Ms. Bell and Darian, here's the question. It appears that this, oh, cool. So you're great because this is an organizing question, I think. It appears that this issue with health inequities has been going on for over 100 years. What can we do as solutions to eliminate the disparities and inequities? So if y'all can each speak to that, and then we'll close. That's Ms. Bell if you're still here, Darian if you're still here, and Naima, whose beautiful face I'm looking at now. Ms. Bell?
That's a very interesting question. I want to just give a little bit of insight. I was reading here recently, and I was reading about how in the late 1700s, there were roughly about 700,000 slaves in the US. And by the mid 1800s, there was about 3 million. And the reason that happened was because cotton had boomed, because they had the cotton gin. So initially it took one slave 10 hours to clean 1 pound of cotton, right? They needed, because of the influx, there was more land that was needed. So what they went to, they went to the banks. You can only grow cotton on one piece of land for 3 years because the cotton drains the land of the nutrients. So they went to the banks to buy more land, and they took out mortgages. And I was thinking, wow, they took out mortgages. But they did not take out mortgages on their homes. They took out mortgages on their slaves because they were collateral. The slaves were more valuable than the house, right? So what we have to do is, as a system, we have to understand that we are no longer the collateral, right? So when you are the collateral, you are our interchangeable part. If you don't work, we can just discard you and we can put something else in place. That is not how we should function. This system is critically sick. And what I have known in dealing with individuals that are sick is some things that need to take place. The first thing that needs to take place is that you need to aggressively attack the infection first. Right? And so what is infected is our mindset, our view, our access. And so we have to take a certain level of accountability as Black people, as white people. We need to determine whether or not we have some implicit bias, whether or not we are the solution or we're the problem. And so it starts at home. The only way that we can fix this problem is if we have candid conversations like this, and if not only when we have candid conversations like this, that we take what we've learned in these conversations and we walk this thing out. It makes no sense for us to congregate on a consistent basis. We talk about all these solutions, we talk about all these changes, we get heightened up, we get emotional, and then what happens is that when we go home, we fizzle out. And I task everybody not to fizzle out. We have to continue strong. The race is a very long one, but we have endured so long that I am so hopeful that we can definitely make it to the end. But I task you to pass the baton, teach our next generation that there is work to do and they cannot sleep on this. And that is the only way that we can change the system.
Thank you so much, sis. Darian, are you here?
Well, I'm not sure that I can follow that.
You can tell us about organizing we need to do, because I know Ms. Bell said that's the only way, and you know, often there's more than one way. We got to work on all fronts when we got so many things we need to attack. So what would you tell us? And you're also our last closing statement. I'll give you 3 minutes. In 3 minutes time, I'll be on you. All right, go ahead.
Oh, okay. So, well, it won't take me that long, but anyway, as I was listening to all of the stories tonight, and I was thinking, you know, I'm constantly saying we are too disconnected as movements in this country. We have to connect each movement to the next and become one movement instead of a fragmented body of people operating around this country. You know, like I've been saying to people, Black Lives Matter, and Black Lives Matter, whether we talking about healthcare, whether we talking about environmental justice, workers' rights, you name it, and you know, Black Lives Matter. So we should all be a part of one movement that we have different elements in the movement, but we're one body working together to achieve the goals we need, which is to make sure that everybody is treated fairly and have the same equal rights in this country, human rights in this country. And so I think the first thing we need to do is how do we become a jointed movement instead of all these moving parts working in our own little silos? How do we come together and make this one movement? And what umbrella do we do that under? Because when I looked at the Black Lives Matter, I said, well, whether we're talking about police violence, whether we're talking about environmental injustice, whatever it is we're talking about, it all comes out to we can't breathe. If I don't have access to clean air and clean water, I can't breathe. You know, and so that's a part of Black Lives Matter. When we say we can't breathe, then we can't breathe, whether we talking about environmental justice, healthcare, workers' rights, you name, again, name it. It's all the same thing, comes down to the same thing. And we have to see it that way and become a jointed body instead of all these moving parts operating in our own little silos. How do we bring all of us together? And I would just like to say one last thing, and I think about my friend, Dr. Steve Wing from the University of North Carolina, who was so eloquent in stating that, you know, as white people, you can't be afraid to give up your white privilege. You cannot fight for justice and social justice in this country and live in white privilege. You can't stay that comfortable. And, you know, when you go home, when you be with your family, wherever you go, you know, like I talk about this stuff everywhere I go. Everybody that know me know, if you run into me, I'm gonna say you know, the same thing I'm saying tonight. And I don't do it based on who I'm around. I do it because it's right, and everybody I know ought to know about it. And so, you know, you have to go and I see George waving at me. I'm finished. Anyway, y'all get the gist of what I'm saying. We got to tell the stories everywhere we go, to our families, at the dinner tables, wherever we go. Again, as I think Dr. Green said, we are not born to hate. It's taught.
Absolutely, thank you. Rebecca, I want to make sure I don't forget anything, but I also appreciate, Naima, that you said, how do we all work on this? How do we get it? NC Medicare for All. We've got the action steps we talked about tonight, the action toolkit that is available. We are your resources. Email us, go to the website, send an email, drop a phone call. We will make it happen. Any other closing comments, James, Rebecca?
I think that covers it.